Today we are speaking about Budd Chiari syndrome. So we are speaking about Budd Chiari syndrome. The patient will come with severe ascites, suddenly severe ascites, and abdominal pain, congestion of the liver. So what is the etiology? The problem is in three hepatic vein, that the right hepatic vein a little bit larger, they meet the inferior vena cava. So the thrombosis is within the hepatic veins. It is partial thrombosis, or two of the three may be obstructed and one becomes large and tortuous with reverse flow. Also, if it occurs, we have many collaterals at the surface of the liver. And also thrombosis of IVC can cause Budd Chiari syndrome. So we know that these three vessels in normal situations meet with IVC, and then with a little bit distance, about 2 to 3 centimeter, it is near the IVC, near comes to the right atrium, tricuspid valve, and right ventricle. So it is the wave of the hepatic veins is velocity time. It is pulsatile. Atrial contraction, systolic contraction, ventricular systolic contractions, and then isovolumetric wave of relaxation of the right ventricle when all the valves are closed, and a kick of right ventricle to the right atrium, and then diastole that is smaller than systolic wave. So it is a normal dip and peak, dip and peak like a W. But if we have thrombosis, if it is partial thrombosis, we have a continuous phasicity like normal portal vein, but it is in the wave of the hepatic veins. So it lost the pulsatility to continuous flow in partial obstruction, then complete absence of any wave. And we know that we have too much collateral, or one open hepatic vein, that for compensation it is larger than normal and with tortuosity, and also maybe flow reversal, uh, opposite of normal situation, that is away from the transducer, or normally hepatofugal, but maybe here hepatopetal, or to the liver. It depends on our transducer and the velocity and direction of the flow. And we know that the liver has about more than 8 segments. The first segment is a segment um, anterior to IVC. So if we have a normal IVC here in sagittal, um, in the left lobe of the liver, we have a caudate lobe that is about 4 to 5 centimeter to 2 to 3 centimeter. And anterior of that is ligamentum venosum, caudate lobe, IVC. And it is independent in nutrition. So in portal hypertension and even in cirrhosis, any uh, obstruction, it has its nutrition and oxygen, so it gets larger. Um, in Budd Chiari syndrome, we have enlarged caudate lobe. Caudate lobe. Caudate lobe is the first segment one in the left lobe of the liver and anterior to the IVC, a little posterior. It is in the posterior part and above the pancreas. We have the Budd Chiari syndrome here. With this one, changing, we don't have any pulsatility, pulse wave, spectral Doppler, no in ultrasound or even gray imaging. We have IVC here. We don't have any hepatic veins, obvious hepatic veins. We have too much collaterals peripherally and centrally in any directions in color Doppler. Okay, and then here we have ascites, and here we have the diaphragm. Even we have pleural effusion, maybe. And if it is the right kidney in Morrison pouch, we have ascites. So we should search for ascites, enlarged caudate lobe, the spectral Doppler changing, and Budd Chiari syndrome is a systemic disease. It is not common. It is a rare disease, and deficiency of factor 5 Leiden or antithrombin 3, hypercoagulopathy or malignancy, especially IVC, thrombosis. So we should pay attention that it is a systemic disease, poor prognosis even, and even maybe the patient needs bone marrow aspiration for ruled out malignancies, very careful ultrasound and studies to find the predisposing factor for Budd Chiari syndrome. So it is very important, all these points. If you have enlarged caudate lobe, search for hepatic veins. Are they normal with color, hepatofugal, all three, and IVC and spectral? So hopefully this short video can help you and is useful. Thank you so much for your attention.